Okay. We'll let everyone in. And Kashif, would you mind keeping an eye on questions for me? And I will ask people for Vivus. This is not interactive, isn't that right?
No, not interactive.
Okay. That's fine. I just wanted to check before we started. Athar, do you mind turning off your slide share for a second, and then we'll restart it in a second? Brilliant, thank you.
Yep.
It will give everyone a few minutes more to join. We're literally on time, so that's unusual for us. So. And please, Kashif, edit that bit out.
Hello, Shuan.
Imran, how are you, my friend? We're going to start in a moment. If you could, I'll find you 1 second and put you as a co-host as well.
Mm-hmm.
Okay, guys, same etiquette as always. Please turn your mics off. Feel free to have your computer on. And we will get started in a moment. Person who's named themselves Zoom user, you might want to change your name to a full name, your proper name, so we know who you are, as opposed to Zoom user. Okay. All right. We'll start now. Welcome everybody to another Wednesday session of the FRCS Mentor webinar and Viva session. Once again, thank you to all the mentors who have joined us today, and thank you to Kashif and Imran, who are on the standby to do Vivas with us, as well as Mohammed Athar Siddiqui, who is going to give us our talk. It's a pleasure to introduce Mohammed Athar Siddiqui. I know him quite well. He's one of the fellows in the Oxford Trust working with the sarcoma service. He's somebody I always value his opinion on, and in both trauma and sarcoma work. And I really am looking forward to his talk today. A little bit different to originally advertised. Instead of talking about primary tumors today, we're going to talk about metastatic tumors, as primary tumor seems to be covered pretty much by everybody else, but how to approach a metastatic tumor for the FRCS orthopedics, I think, is quite an important topic. And without any further delay, we look forward to Mohammed Athar Siddiqui's talk. Thank you very much.
Well, thank you, Sean, for your kind introduction. And I value your opinions on a lot of things besides clinical work, you know. I'll just share my slide, guys. Are we good? Can you see my slides?
Yes, it looks perfect. Thank you.
Okay, let me just go to presenter mode. Okay, so yeah, thank you everyone for giving me the opportunity to talk to you today. Yeah, the reason I sort of, at the last moment changed the topic, I know it's not nice, but the reason I changed it was mainly because I think primary tumors are usually covered on almost every FRCS course you go to. People will talk to you about the big three and obviously soft tissue sarcomas. The other thing is obviously management of bony, metastatic bone disease has continued to be a challenge and is still very relevant to the general orthopedic practice rather than purely a sarcoma problem. And again, there are some principles that are still evolving. There are some guidelines that you need to know, and I'm going to touch briefly on the boom audit, which is about to be published, conducted by Birmingham. I think it was presented at the Boost this year, and it's going to be public. It's publication, so it should be. We should have the published results in about 3 months' time from now. So yeah, just as introduced by Sean, I work as a sarcoma fellow with the Oxford University Hospitals, and mostly our work is around bone and primary bone and soft tissue sarcomas. We do have a regional metastatic bone cancer or bone metastatic disease network, and we'll talk about what the network is and how it works in terms of how the referrals work for those of you who haven't worked in the world of cancers that much. Well, why we want to talk about what our objective for the talk will be to describe or have a systemic approach to when you're presented with a case with a pathological lesion, whether it is in your vivas or in your clinicals, and then how you would evaluate a pathological lesion, especially with an unknown primary, which is, I think, a lot of people on the mentor group will tell you that this is quite a common presentation on your exam. And then we'll finally also touch on the current management principles and the evolving principles of managing pathological fractures, and obviously some of the new technologies. I've got a lot of raised hands. Are there questions? Is there a problem with anything? A lot of people with raised hands.
No, actually, they're just raising their hands in preparation for the Viva. They're always excited.
Okay, fine.
But could I make a suggestion? My apologies, Athar. When you turn your mouth away from the mic, we do lose your voice a bit. So if you could be kind enough to keep your mouth towards the
I'll
mic.
keep myself headed towards the computer.
Thank you so much.
Okay, so the incidence of metastatic bone disease, is it common? So yeah, 12 to 70% of all presentations overall in bone cancers will be metastatic disease. It's a very wide range, and obviously it depends on where you're working and how these papers have been reported. So yeah, I would say, yeah, it's one of the most common. The bone is the third most common organ for METs. We know that metastasis for breast is the second most common. And a key question, I think, I'm sure on your MCQ test, you would have had a key question of, what are the common osteophiles from where you get bony metastasis. If you look at how common the problem is on autopsy slides for people dying with cancers, 90% of people have been found to have skeletal METs, and I mean a lot of them are occult. So these are autopsy studies. So how do they present? Well, they present with pain. They can present with immobilization. They're off their feet, especially when they have got either an impending pathological fracture or a pathological fracture. Now, how does this affect us as surgeons? So it is basically quality of life, which is altered here, either because of pain or because they're off their feet. And remember, when there is a skeletal metastasis, it is already advanced stage disease. So you need to start thinking of quality of life surgeries and survival, and how you're going to affect all of those factors in planning your management, rather than curative on most occasions. But there are curative options, especially if it is a solitary metastasis, and we'll touch briefly on that as well, and how the approach is evolving. So where do metastases occur in bone? So most of the metastases, we know that the bony metastases are usually hematogenous metastases, and therefore it is almost always in the well-vascularized skeleton. So you will talk about spine, pelvis, the metastasis of long bones, the upper extremities. But yeah, upper extremities are frequently, they've got a better blood supply as compared to lower extremities, but those are the sites of bony metastases. So remember, spine, pelvis, proximal femur, most favorite sites, but you can have other sites such as ribs, skull, and upper extremities as well. The incidence of pathological fractures is about 7 to 10%. But yeah, most common sites of primary, as I said, are breast, prostate, lung, kidney, thyroid. So those are the 5 most common osteophiles. You need to remember that for your for those of you who've not done your MCQ tests, and you might have that on your MCQ, followed by colorectal. And then obviously you've got hematological conditions, myeloma and lymphoma. And then finally we got melanomas also metastasizing to bone. Unknown primaries, again, you can have a presentation with primarily bone involvement where a patient comes to you with either pathological fracture or a painful lesion in the proximal femur or the pelvis, and you don't know the primary, and then you obviously have to systematically work up on how to investigate these people. Well, yeah, if you look at that paper, which is fairly recent, again, the most common is breast, followed by the rest of them, and unknown is also quite common presentation. In fact, it's much more common than some of the other primaries that we know of, such as prostate, renal, and lung. So they present with pain, and when you're doing your cases in FRCS, you would be expected to differentiate between mechanical and biological pain. Now, how that is important is in determining what to do with, how urgent your management is. So mechanical pain is basically pain on mobilization, weight bearing, for example, in the lower extremity, or movement in the upper extremity. Whereas biological pain is chemokine or mediated, and that's usually pain at rest and night pain. So you have to ask about character of pain, whether it's localized, is it intermittent, and is it increasing in intensity progressively? Obviously, biological pain will be characterized by night pain. And then you could also have referred pain due to nerve compression of a tumor. You could also have neurological deficits, and then a bladder or bowel dysfunction, spinal metastases, as part of syndromes such as cord compression and cord equina. Primarily, this talk is not on spinal metastasis, so I'm not going to touch too much on that topic in my talk. So again, you have to take a pertinent history of anorexia, weight loss, other, history of smoking, tobacco use, bowel habits, and then you also have to ask about early menarche and late menopause as risk factors for cancers of uterine and breast. And then family history is important. Obviously, when you're given this, especially in your clinicals, then remember. So I was vivaing a group not so long ago, and I can see some faces from that same group on this group as well. So review of systems is very important, not only on your history, but also in your examination. So don't forget that on your clinicals. That saves you a lot of, and that actually gets you brownie points, and then that can save you from digging holes for yourself when you're doing your clinicals. So review of symptoms is very important for all presentations, and it's obviously very important for metastatic bone disease. So on the examination, again, start with the general physical, look at weight loss, nutrition assessment, and then systematic examination will be breast, prostate, abdomen, chest, thyroid. You would also look for local examination, which is the presentation of the lesion itself, which will usually present with a mass or swelling. Look at overlying skin, whether there are distended veins, whether there is an inflammatory component, and the skin is warm, shiny, distended, and this will possibly show you whether the tumor is necrotic, and there's an inflammatory component to the whole thing. Then obviously have a detailed neurovascular examination of the extremity. Examine always the lymph nodes. You will fail, at least I would fail you if you don't examine the lymph nodes for any tumor case. We know that most tumors, most primary bone and soft tissue tumors, do not metastasize to the lymph nodal route, but as part of your scheme, you should always include that. for cancers, you should always examine the lymph nodes. Again, going to laboratory studies, you should have your primary profile with your full blood count, your biochemistry, and your coagulation. Talk about a myeloma screen, always with lesions, especially with multiple lesions. Talk about your urine analysis and specific tumor markers, especially in the workup of tumor of unknown primary. A lot of oncologists will do your PSAC and CA129 as markers to investigate. And then coming specifically to the lesion itself, obviously start with X-rays in orthogonal planes, X-ray of the whole bone to look for skip lesions within the whole bone. For example, if it's proximal femur, then you would want to have radiographs of the whole femur, AP and lateral. Always talk about cross-sectional imaging with MRI or CT scan, MRI being the gold standard. You have to speak about getting an MRI, if not otherwise contraindicated for any reason, such as a pacemaker, where you can't get one, or metallic stents. But always talk about an MRI, especially in the solid metastases, whether it's fractured or not, because you want to get your local staging sorted. Now, systemic staging, you can talk about PET scans. That is what we do in Oxford, but obviously within the UK, there is no consensus about what is the investigation of choice, whether it's for primary bone tumors or for metastatic lesions. Now, a lot of metastatic work you would see in DGH, and there are regional metastatic leads in hospitals. Now, not all of them have access to PET scans, and CT chest, abdomen, pelvis is a reasonable investigation to do for metastasis, and that's perfectly acceptable as an answer on your FRCS exam. So yeah, local radiology and PET scans can also show you local disease. So that's why you can talk about PET scan. Bone scans are mostly a thing of the past when it comes to current sort of accepted norms, but yeah, still hold value if you have got nothing else. You can talk about all those options. I'm not going to go into the exact details of how specific and sensitive each one is, because I don't think that is expected of you on the exam. That's a little more advanced, and maybe if you're following a career in tumor surgery, then you would be asked those questions. Well, so on X-rays, most of these lesions would be either, so you would classify them as either lytic, blastic, or mixed. It's nice to remember which ones present more commonly with a certain pattern. Remember, the diseases never read the book. So prostates would usually be blastic, breast would be mixed, lung would be lytic, renal and thyroid would be lytic and expansile, fairly expansile. So how that happens is, I think it's got to do with vascularity. The more vascular the lesion is, the higher the bone turnover, and usually that presents with lytic and expansile lesions with a lot of cortical destruction, and they very rapidly progress to causing a fracture, and usually present with a soft tissue component fairly soon. So yeah, renal and thyroids are the metastases that nobody likes to treat. Prostate and breast are the ones that are good in terms of surgical as well as overall prognosis. Lung, well, metastases are not that difficult to treat, but overall the prognosis of these patients is fairly poor. So now just a caution about X-rays. Well, before you see a lesion on the X-ray, 30% of the bone is already lost, right? So yeah, these are just some examples. There's a lady who presented to us with multiple metastases, one in the proximal humerus and one in the right pelvis. As you can see, that there's a mixed component. There are lytic areas, predominantly I would say in the proximal humerus, but there is a blastic component. You can see sort of bone forming lesions within the whole thing. There is a pathological fracture here though, and you can see that there is some callus that's already forming. Well, when she presented to us, she had already had some radiotherapy before presenting to us, and then we had this lesion in the right ileum, and again you can see there is a mixed lytic and blastic pattern to this lesion. But look at how renal cell cancers present. So this is a lesion in the proximal humerus of a very young chap with renal cell cancer. He was just 54, and this presented to the DGH clinic with a proximal humerus lesion. Well, the oncologists blasted it with some radiotherapy. And look at this, this within 2 months of radiotherapy, he just progressed very rapidly. We had to do a sort of 4-quarter amputation to salvage because this tumor was just bleeding within his compartment, and he basically presented with compartment of the upper extremity because of the way the tumor was growing rapidly, and we had to sort of do an amputation. But he died fairly soon after the amputation. Anyway, so yeah, lung is again lytic. This is metastasis in the acetabulum, and you can see that the inner table of the acetabulum is eroded with a large soft tissue component in the iliacus, going on towards the pelvic viscera. There was a previous pathological fracture of the proximal femur that was fixed with the DHS implant, as you can see. I'm sorry, I don't have the full x-rays. This is not a UK patient. This is from my previous work when I back home. So yeah, I mean, those are just examples of how they present. And again, thyroid is very rapidly blowing out, almost like a shark bite. Again, a supraacetabular lesion, and you can see the soft tissue component. So that's why cross-sectional imaging is just so important, because you don't know what the extent of the lesion is on your radiographs, and you really need cross-sectional imaging to tell you how big that tumor is. And you can see that there's a huge component, soft tissue component of that tumor, extending all the way into the iliacus, blowing up on into the external surface, into your gluteus medius, if you would like, and minimus is totally involved with the tumor, especially anteriorly. So prostrate, usually blastic, very difficult to pick often, and they can be missed. But remember that if somebody presents with proximal femoral pain, history of prostate cancer, with this femur, especially elderly males, you wouldn't expect them to have very good bone density at that age. And then don't mistake this for you can clearly see that there's sclerosis on the middle near the calcar, and then this is usually metastases. So yeah, bone scan. You would want to know something about bone scans on your exam. I know it comes up as a basic science question often, rather than on your cancer viva or on your sarcoma or metastatic bone disease viva. But yeah, you should know that it basically is sensitive but not specific. It demonstrates skeletal activity and involvement earlier than X-rays. It is ideal to detect occult metastases, especially in a patient who's presented with one lesion. You can do a bone scan to find out other lesions, but it doesn't give you any information on bone integrity, and therefore usually will have to be combined with either CT scan if you want to investigate a particular lesion. It can be used to monitor treatment response. However, you don't have specific values, and that's why it is again all you look at is flare phenomenon, and that's why it's being replaced with PET scan, where you've got SUV, which is the uptake standardized uptake value, which can actually give you a treatment response and quantify your treatment response rather than just a flare phenomenon. So yeah, the flare phenomenon is due to newborn formation and treatment. We all know that, and we know the 3 phases of the bone scan. I'm sure you're all aware of that. So CT scans give you detailed information on bone integrity, especially cortical involvement. And if you're worried about impending fractures, then you can get CT scan on lesions that present with pain. They're very good for difficult anatomical areas to see complex anatomy in the pelvis, spine, and the shoulder girdle. And look at that. That was a lesion that appears to be very small. Looking at a CT scan, you can see that how wide the involvement is, and it's almost involving more than it's almost involving 80% of the cortices of that tibia. There's going to fracture unless something is done with that. MRI, again, a good investigation, and actually the gold standard, especially for solitary lesions. You have to MRI with gadolinium enhancement, which will give you extent of intramedullary marrow involvement. And I think yesterday or a while before, somebody did ask me on another session. So when I request MRI, what do I need to request? So obviously on your request, you will write that I will get MRI with gadolinium enhancement, and I will scan the whole bone. So if the lesion is in the femur, you do an MRI of the whole femur, not just proximal femur and not just the femur. And why you need to do it is to detect skip lesions, whether it's for primary bone tumors or it is for metastatic bone disease. You need to scan the whole segment, the whole femur. If it's in the tibia, then scan the whole tibia. If there is spinal canal involvement or cord compression, again, scan the whole spine. So, yeah, contrast enhancement is used to differentiate the true boundaries of the lesion, and obviously to see the inflammatory component of the lesion. If there's perilesional edema, either within bone or within soft tissue, and also to delineate your hematoma boundaries if you've had a fracture. And obviously, if it is post-articular, then you have to evaluate the adjacent joint for concurrent pathology or an intra-articular fracture or involvement of the synovium and seeding through the synovium, and therefore it will eventually alter your management, your planning. So yeah, that's so I can't remember what lesion that was, but that was a metastatic lesion to the proximal femur with a fracture through the front of the neck. And if you look at the X-rays, if you look at the proximal femur, I mean, most of you would say that there was a pathological fracture. As you can see that small lytic lesion in the neck through which the fracture has happened. You can also see the DP, but the lesion in the subtrochanteric area is not very clear. And had we not had an MRI scan, you would have missed it. There's another example of how an MRI shows you the extent of the disease. So if you see that proximal femur, you can see the disease segment in the proximal femur. But once you get an MRI, you can see that diffuse involvement is just going way down. And actually, this patient had disease all the way down to the distal metastasis. And look at that. That's a cross section. You can now see what the soft tissue involvement is like. So had we not done that, we would have missed what the soft tissue component was like. So yeah, talking about PET scans. So PET scan is, as you know, 18 FDG, which is fluorodeoxyglucose, and this identifies metabolically active areas as more glucose is taken up by metabolically active cells, and these could be the indicative tumor. So generally it's accepted 2.5 to 3 is indicative of tumor. That's the SUV, as a standardized uptake value. It is again non-specific, but it is finding good role now, especially as a prognostic tool to monitor response and basically see if chemotherapy or radiotherapy is decreasing your SUV, even and it's finding use in primary bone sarcoma as well. Now, talking about biopsies, the first question is, when would you do biopsies? So you would do a biopsy definitely in a solitary lesion of bone, whether the patient has previous history of other cancers or not, and whatever the age of the patient is. Because a solitary lesion in bone, by principle, is a primary bone tumor unless you prove it otherwise. So you have to prove that this is metastatic bone disease, and you just cannot assume that this is a metastatic lesion. So in a patient with a known primary, you would confirm the metastasis. In a patient with obviously an unknown primary, you have to investigate, and then you have to think of other lesions such as Paget's disease, which we know that is precancerous, and you also have to rule out metabolic bone disease such as Brown's tumor. But yeah, you will obviously be helped with your profile, with your bone profile, including PTH in that. The other thing you would want to do for your biopsy will help you determine is obviously disease progression. If there are multiple sites, I remember a case when I was a very junior sarcoma surgeon many years ago, and this guy had prostate cancer with a lesion in the proximal femur, and when we did an MRI, he had a lesion in the distal femur, and we did a biopsy, and that turned out to be osteosarcoma. So he had two lesions in the same bone. One was metastatic prostate cancer, the other one was osteogenic sarcoma. On further inquiry, so he had come in with unknown history. We didn't know what he had had before. So he had had a synovial sarcoma resected from the back of his knee, and he had had radiotherapy. So this osteosarcoma was basically radiation-induced osteosarcoma. So yeah, you can have very weird presentations. So that's why do biopsies. If we had assumed that his distal femur lesion was just another metastatic lesion of the prostate, he would not have had chemotherapy for his osteosarcoma, and hence his survival would have altered. Well, his prostate cancer was, the metastasis from the prostate cancer was again solitary metastasis. So yeah, and the other thing you can do with biopsies is get tissue for your for hormonal studies, and we know that certain cancers, especially breast and prostate, have got immunotherapies available. Even lung cancer has got immunotherapy available now, and that's why as oncologists are becoming better in treating this cancer, treating their cancers, metastatic bone disease is probably the next medical epidemic we're looking at. And as orthopedic surgeons, we will need more and more surgeons to be able to work with metastatic bone disease, because sarcoma surgeons would just not have time. It's overwhelming. These patients are surviving longer. They've got these nibs and nabs, as one of my bosses likes to call them, the imatinibs and all the family of the nibs with immunotherapies and monoclonal antibody therapies, which are getting these patients to survive longer, and therefore they present with mets, and they have longer survival. So that also has an impact on how you plan your management. So yeah, biopsy types. We all know about needle biopsies and open biopsies. Needle biopsies can be, we don't do FNACs in bone or soft tissue cancers. We do core needle biopsies. That is a preferred method. That can be ultrasound, CT, or fluoroscopic guided biopsies. Open biopsies can be incisional, which can be at the time of surgery. And then if you've got a tumor that you can access, so for example, if somebody presents with a lesion within bone, but then on screening, for example, on breast examination, they've got lesion in bone, then just biopsy the breast lesion as well. If they've got lesion in their thyroid, then biopsy the thyroid lesion as well. And incision biopsies are sometimes required if a core needle biopsy fails to show you results, especially if they cannot be repeated, or if there's a risk of incision, impending fracture, then you just need a quicker answer. Excision biopsies for metastatic bone disease usually not performed. Very rarely, especially in expendable bones, such as proximal fibula is an example, or maybe the ilium. But again, I will do it without a corneal biopsy usually. So let's get through that. So again, coming to management, and your management needs to, when you're asked on your exam about the management plan, you need to talk about how you're going to approach this patient. So it all depends on how the patient is presented to you. So if the patient has presented to you with pathological fracture, you still need to get certain information. So you need to know their primary. If they have a known primary and they're under the treatment of an oncologist, you need to tie up with the oncologist. You need to know whether this is a solitary lesion or there are multiple metastases. And you need to know their ultimate survival with their current status. So these are the questions you need to ask right at the onset. Then a management plan has to be formulated on an MDT, and this has to be the regional metastatic MDT. We'll talk about how that network works. So there is a sarcoma MDT, and then there's obviously regional metastatic MDTs. So there are obviously in the UK, there are the sarcoma network. There's a sarcoma network with centres in London, at Stanmore in Oxford, which is us, at the Nuffield, and there's Birmingham, which is the ROH in Birmingham. Then obviously there's Oswestry, and there's one in Newcastle. Then there are up north, there's one in Glasgow, and there's one in Edinburgh. So those are the primary bone and soft tissue cancer centres who also deal with metastatic bone disease. But then there are regional metastatic leads. For example, in our region, there's one in Bristol, there's one in Milton Keynes, there's one in RBH, so on and so forth. So they are, by principle, required to have their own MDTs, but they've got the oncologist coming in and discussing these patients, formulate a plan, whether they are good for non-surgical management or versus surgical management. So non-surgical management options, which are usually instituted by oncologists, are hormonal therapy, chemotherapy, or immunotherapy, bisphosphonates, radiotherapy, and radiopharmaceuticals such as strontium-89, which has been used for prostate cancer, and iodine-131, which is used for thyroid cancer. Coming to surgery, which is our job, and you will be asked on this, your viva, and that's where you want to earn your points. So the intent of surgery is key here. So the intent should be problem-oriented, so you need to find out what the problem is. You would want to enhance survival if possible, and that is usually in this scenario of a solitary bone metastasis, where you can actually perform curative surgery by doing a wide resection. But the key to remember is whatever surgery you do should be the only procedure you do in this patient. So try not to do a surgery that is inadequate and avoid future intervention. That is key, especially when treating pathological fractures. So don't just fix things. You want to give this patient one surgery, they've got limited life expectancy. You don't want them to come back and have repeated operations. Considerations are general condition of the patient, their general comorbidities, their functional status, daily living, and very important is life expectancy. So their disease, the disease-specific survival is important. So that's your buzzword for your exam. I would want to know the disease-specific survival for whatever disease they have. The goals are pain relief, obviously preservation or restoration of function, facilitating nursing care at times, and obviously getting local tumor control, especially in the case of pathological fracture. Principles are preoperative planning and obviously planning the approach. Preoperative planning would include angioembolization. You have to say that I'm going to look for angioembolization, especially for renal cancer, renal cell cancer, and thyroid. Don't say I will consider, just say I will do, because that's what all of us do. Perioperative antibiotics is important. These patients are sick patients. Their immunity is low. They have had chemotherapy. They might have had local radiation. So you would consider perioperative antibiotics. There are people who argued whether extended antibiotics are indicated. There's no evidence on that, and there is an agreement on that. So you would consider your standard antibiotics according to your trust guidelines for revision arthroplasty. That's the answer for the exam. You correct anemia, you correct their coagulopathy, you correct thrombocytopenia, and very importantly, you have to correct the hypercalcemia of a lot of these patients have got metabolic derangement, especially with hypercalcemia. Approaches, the principles are 2 standard surgical approaches when possible. Incorporate your biopsy track, obviously. Try and avoid irradiated skin if possible, but usually it's not possible. But those are the sort of principles you mentioned when planning your approach. So when do you resect and when do you perform a palliative skeletal stabilization? So solitary metastases, you would resect. Yeah, multiple metastases, you can perform skeletal stabilization. Again, the site is important. Whether you can resect, technically, that's important, and the overall survival of the patient is important. And then if they are on chemotherapy and if they are on life-saving systemic treatment, if your surgery is going to keep them, away from, for example, if you do an endoprosthetic reconstruction, the patient is stuck with wound healing problems, high risk of infection, and you're keeping them from their chemotherapy or further radiation, and you're not doing a patient a service. In fact, it's a disservice. So it might be reasonable to stabilize them, do a quick procedure, and get them off to the oncologist to carry on with the immunotherapy and radiation if that's required. So again, the other factor is whether the bone is intact or have you got a fracture, and how big is your hematoma. So patients with isolated bone mets as cancer relapse can obviously undergo intended curative resection with potential prolongation of your disease-specific survival. So that's where you would always do resection, right? And when you've got complete bone loss, so as we call vanishing bone, if you remember that X-ray that I showed you for the renal cell metastasis, had this guy not had such a horrendous presentation with compartment syndrome, we would have had to resect. So vanishing bone, you resect and you replace. So principles of skeletal stabilization: don't just put a nail down. Okay, the principle is composite osteosynthesis for multiple metastases and pathological fractures. So if you can't resect and reconstruct, which is by far, I think resection and reconstruction with endoprosthesis is becoming more and more common for metastatic disease, rather than just fixing it with a plate or shoving a nail down. And even if you are to go and put a plate on, you have to open up the tumor, have to get as much tumor out from there as possible. Obviously, you don't want to end up with a lot of bleeding. So always do preoperative embolization for renal cell metastases and thyroid metastases. You put a lot of cement in, and then you do your osteosynthesis with the cement. So that's composite osteosynthesis. Cementoplasty, either a plate or a nail. And in the pelvis, there's Harrington reconstruction method, which you do putting Steinman pins in and cement. And that's how you reconstruct. So yeah, you want to have immediate rigid internal fixation. You want to get them on their feet with immediate weight bearing. You have to assume that these fractures are not going to heal. So that's why you correct all the tumor, put cement in, and you span the entire length of the bone wherever you can. Intramedullary fixation is definitely preferred over extramedullary fixation. So yeah, and prosthetic replacement for juxtaarticular involvement is by far the commonest practice. So examples of is the mid-shaft lesion of the humerus. Yeah, ideally, this is quite an old case. I think I did this about 6 years ago. I curated the lesion out of the humerus and then put in cement and a humeral nail. The patient did really well in terms of I mean, their survival. I think this was a, can't remember what primary it was. I think this was a prostrate primary, if I'm correct. No, sorry, it was a lung primary. I remember now. So there's another lady who had a breast cancer metastasis. She had a neck of fracture, and somebody had put a PFNA down. Obviously, it went on to failing. Then we had to put this custom sort of hip prosthesis in, which was car bearing implant. What I wanted to show you is on how we. So she had a distal femur lesion as well, and you can see that it was curetted, and you can see that cement all the way coming out, curetted, and that was cement, and then we put the longest stem possible down, and on her feet next day. So yeah, what do you do with pathological practice, and how, you know, how do you work them up? So you have to think of whether this is already a fracture or it's an impending fracture. Impending fracture, what is key is pain, obviously location, size of the lesion, whether there's medullary cortical involvement, and whether the primary tumor is responsive to radiation or systemic chemotherapy, the age, health status, level of prognosis. Prophylactic fixation can be argued. There are many studies and many scores for prophylactic fixation, are not accurate, and you've all heard of the Morel score. You can quote the Morel score, but don't. I mean, it's really not on the money these days. There are other MRI-based scores coming up now, talking about other things such as endosseal resorption, which a Morel score really does not incorporate. And we know that endosseal resorption reduces the strength of half the cortex, reduces the strength by 70%. Therefore, MRI scores are being worked up by different centers. I think we are doing a study on one, which we intend to publish later, hopefully when we've got enough data. So yeah, painful illicit lesions larger than 2.5 centimeters on cross-sectional imaging are the ones that you would really want to fix rather than just leaving them alone, especially in the lower extreme. Functional pain after radiation therapy is also indication for fixation. Again, for spine lesions, look up the SIN score. I think when I was in the exam, we were doing Kashif, is it? And then, but the guidelines are use the SIN score. You don't need to remember the score. I think by the time you get the spinal instability score, you probably doing quite well on your Viva. So again, some of the other things that are available besides fixation is cryosurgery. This was during my fellowship in South Korea. We used to do a lot of cryosurgery for metastatic as well as primary bone sarcomas. Indications were for failed radiation, obviously for renal cell and metastatic thyroid cancers, where yeah, it gives you immediate control of bleeding as well on table, especially in tumors in difficult anatomic locations where radiation therapy might be difficult, such as the pelvis. Is an example of a case that I did with my boss, where there was this lesion in the sacrum, very vascular. You can see we had pre-op angioembolization. We then made a hole through the lateral sacral wall. And then curetted, got away with preserving almost, complete bladder and bowel function. So I'm acutely aware that we're running out of time. Just to touch base on radiofrequency ablation, again, a technique more of an Asian thing, but it's quickly coming up in the US, which is, percutaneous aspiration of tumor, then radiofrequency ablation and percutaneous cementoplasty. Again, as the technique is evolving, people have tried it for tumors greater than 2 to 3 centimeters. So I think it started in Korea and Japan, and recently on MSOS 3 weeks ago, I saw that Yale University has started it for big lesions, and they showed very good response to this percutaneous CT guided cryoablation therapy. where they've been able to create ice balls as big as 5 centimeters in size to basically ablate these tumors. And they've done it for pathological fractures. I don't know how, and most of the people who were attending that session didn't know how, but those are the cases they show. So basically, you can get some, if you're doing really well on your Viva, you can sort of mention the recent advances are, percutaneous cementoplasty and cryoablation. Remember, amputation is not a failure of treatment. In fact, it is treatment. There is limited role in treatment of metastatic carcinomas, though, where the indications are really advanced cancer leading to intractable pain, a functionless extremity, fungating tumor, presenting with vascular occlusion and gangrene, hemorrhage, compartment syndrome, obviously an infected tumor are all indications for amputation. And yeah, there are percutaneous solutions such as vertebroplasty in spinal metastases. Pitfalls are expecting the tumor to heal, the fracture to heal, expecting pathological fractures to heal, and that is the radiograph, I believe, of the lady that I showed you that we did a long stem sort of a hip replacement bipolar on. You could argue why we didn't do a hip. Yeah, we didn't do a hip because I think we didn't do a hip. But you can see that that lesion in the acetabulum, somebody had done a nice mesh and impaction bone grafting on with a cemented cup, but that obviously failed, and we had to actually resect the lesion, and we left him with a hanging hip. Really, that's basically a sort of girdle stone, and he was really happy with that. So we had to angiomolize his pelvis, and we actually did a type 1/2 hemipelvectomy on him. So just further reading, and there's the NICE slide. So you need to know the NICE guidelines in metastatic disease. You also should read up the Bruce guidelines, and especially the 2016 revision. Those are the links. And the most recent thing is obviously the BOOM audit, which was conducted by the Birmingham group last year. I think this was around, actually they completed their recruitment in July. And this was basically to see how many centers were following the BOOS guidelines, 2015 guidelines. The results were presented a couple of months ago to the sarcoma audience, and they will be published for everybody to see in about 2 to 3 months' time. They're really very poor results, with only 40% of these cases being referred to specialist sarcoma leads, 30% of them being actually discussed on MDTs. So by far, even in developed NHS, as we claim, we are still far from anywhere near, not perfect, but even saying these are very, very poor results, not even mediocre results in terms of how we are dealing with metastatic bone disease. Today I did a total femur on somebody. They put a plate on for a periprocess fracture in the midshaft of the femur with a total hip and a primary knee on, and they realized that this was a radiation-induced osteosarcoma on a background of previous radiation received for a lymphoma. So yeah, I think whenever you see a lesion that you're not sure of, pick up the phone, contact your nearest either metastasis lead if you think it's a metastasis or a sarcoma center, and we will give you advice. So yeah, that brings me to the end of my talk. I've taken the whole hour.
Thank you very much. I thought that's an excellent talk. It's also quite interesting about for reiteration of the importance of the MDT approach, liaising with the sarcoma service. And if you have any doubts, seek advice. Don't be a hero in these scenarios. We have a couple of questions. First of all, question from me, if you don't mind. In these solitary lesions where, for example, let's take a renal carcinoma, for example. You've got a solitary region. We know it's curative if you do an excisional arthroplasty with them as an, let's say, proximal femur. Would you biopsy those patients knowing that there's a renal, doing a CT scan demonstrates a renal and it's a large lytic lesion? Or would you presume it is based on the MRI scan and the same vascularity?
So solitary bone lesion, always biopsy, even if you know a primary.
Okay.
Even if you've got, so you always have to biopsy to prove that this is solitary.
Yeah.
Principle, solitary bone lesion, always biopsy.
And one of the probably trip-ups in the exam would be if you're biopsying a renal cell, you still do the embolization and then come back and do the embolization when you do the definitive surgery as well.
Yeah, that's a good question. That's a very good question. I think we have had this scenario more than once in the recent past when the question has been on referral on our radiology MDT, whether you want to biopsy and knowing that there was a renal cell primary or there was a prior history of a nephrectomy for renal cell cancer. Now there's this big lytic lesion in the proximal femur. I think it all depends. If the lesion, radiologists and specialist musculoskeletal radiologists with experience are not too bothered about a lot of bleeding when you're biopsying a lesion that's well contained within bone and that doesn't have a lot of lysis. But you have to look at the vascularity on your contrast enhanced images. And we've done biopsies on these lesions without a lot of bleeding. So basically fluoroscopic guided biopsy. But yes, if you're really worried about bleeding, then you can angioembolize before the. But usually that's done for pathological fractures. If you want to biopsy a pathological fracture, not sure about, that's when you angioembolize. But usually with a pathological fracture, you wouldn't biopsy. You would just go ahead with surgery.
Yeah.
I don't know if that answered your question. Or
it does. It's because it is a complicated thing, but it's demonstrating safety in the exam that you are thinking on your feet. Also, recognizing that these are very I forgot the word, plastic or angio-loving. They cause new angiogenesis very quickly. To keep on that theme, what is the maximum duration between embolization and any intervention? That's a question from one of our candidates.
Excellent question. So ideally, you would want to do it 24 to 48 hours before the operation. It can be done earlier, but the whole argument is that how big the tumor is and what is your total volume of angioembolization. Because as soon as you angioembolize, well, we are hoping that it is a successful angioembolization and you're cutting off the vascular supply, the tumor starts dying. And it starts dying very rapidly. And suddenly you've got a necrotic mass. Now, number one, if you do it very early on, then you've got the risk of your patient becoming really sick with the necrotic mass. Number two, you will soon have a lot of edema and necrosis around this tumor, and which will make your surgery technically difficult. So ideally, it's 24 to 48 hours. Although we have had situations when we've done it 4 to 5 days in advance for small lesions. But yeah, that's the sort of time frame you're looking at.
And sorry. And then another question from one of our candidates. In case of open pathological fractures, how to manage? Is X-fix allowed? Is there any different principles in terms of open fractures? I would say that's extremely rare case. But from experience, pathological fracture is low energy generally, but I suppose it can happen. Yeah.
Anything can happen in life. Well, it's difficult how to answer that in the exam. I don't think you will be asked that in the exam, but if you want to go that extreme, but so pathological fractures with which present as an open fracture, we're possibly looking at an amputation rather than X-fix. X-fixes by principle are not allowed in pathological fractures whether or not it's an open or not. Yeah. So if you're looking at an open fracture with a pathological fracture, you're looking most probably at an application. You're not going to X-fix it.
Yes, that's correct. Thank you very much. If there's no other questions, and if there is any questions, if anyone wants to ask, just quickly type or even unmute your mic and ask. That's okay. But if there isn't any more questions,
John, I have a question. Sorry,
thank you, Imran. Please go ahead.
the hand has been raised for some time.
My apologies, I hadn't seen it. Sorry.
Yeah. Thank you very much, Ather Siddiqui, for a very wonderful lecture, very excellent and enlightening. I just have one question to clarify. When I was in Stanmore last year, we referred lots of patients with osteoma of long bones for radiofrequency ablation.
Yeah.
But I'm not sure what the guideline is for spinal osteoma. Can you shed light on that, please?
Okay, fine. So the guidelines for osteoid osteoma, being a benign primary tumor of bone, the gold standard is radiofrequency ablation. You're absolutely correct. If it is an osteoid osteoma in an area, I think virtually everything, I haven't had to resect an osteoid osteoma for the 7 years that I've been sarcoma surgeon, except one kid that did not respond. I mean, failure of radiofrequency ablation is an indication for resection or actually curettage of the osteoid osteoma. So the guidelines, I don't know what you mean by guidelines. Well,
no, my problem is, so we have treated lots of osteomas of long bones on the femur, proximal tibia, upper limb, but I'm talking about the ones affecting the posterior elements of the spine, because I've had a discussion with spinal surgeons, and some of them were dubious about use of radiofrequency ablation in the spine. So I'm not sure about the ones affecting the spine.
Well, I'm not a spine surgeon, but I know that in Oxford, we do radiofrequency ablations on almost all osteoid osteomas in the spine as well. We are not very, so remember it's a disease of the posterior elements, as you rightly pointed out. It is usually a cortical-based lesion, and the accuracy of radiofrequency ablation and how much of a halo you can, so thermal halo you can create is very, the technology is very good now, so they know exactly how much to give, and our radiologists are very comfortable with that. So but yeah, if it is refractory to treatment, you can always go in and operate, right?
Yeah.
Personally, I'm not a spine sarcoma surgeon, so yeah.
No, but I can confirm.
On our IMD team, we do all the osteoid osteomas, and we do them radiofrequency ablation.
Yeah, no, I can confirm this has been. I've seen this being discussed in our spine team. The Oxford spine teams have discussed these cases before, and they're invariably done by radiofrequency ablation in Oxford.
Yeah.
Okay.
Thank you. Yeah.
You're welcome. Next case. Does wash with sterile, sorry, next question. Does wash with sterile water instead of normal saline have any value in tumor cases?
You tell me.
I don't know that. I haven't come across something like this. I don't think.
Not you.
No.
The gentleman is asked.
You
unmute yourself. Ahmad Shoki.
Shoki. If you want to unmute, you're very welcome to. If not, that's okay.
So we were doing a total hip for a prostatic mets. So the consultant mentioned that sterile water is considered to be like inhibiting this tumor tissue rather than washing with saline. So I just want to clarify this.
It doesn't inhibit tumor tissue. Well, sterile water, whatever cells you've got in your field, well, it will just because you're hypotonic in the intracellular matrix and you're hypotonic outside. The cells that are detached and avascular, they will just die, right? So it is used to wash. Yes, you're right. In primary bone tumor surgery, we use sterile water rather than saline as our wash of choice, because then you're also treating cavity. So if there are any tumor cells that are spilt, they will die, right? So you're absolutely correct. But you need to know why that happens. They don't inhibit the tumor cells. They inhibit every devascularized cell that's floating around in your surgical field.
That's interesting. I never knew
It will
that.
imbibe water and die. Yeah,
That's very interesting.
Sorry, can I mention it's the buzzword here is osmolality. So it is hypoosmolality, which means that the water will go into the cell because of the lack of electrolytes outside in the sterile water. So the cell will allow too much of the water into the cell, and a lot of the electrolytes will go outside the cell, and then the cell itself will just explode.
Thank you.
Thank you, Abdullah.
Next question, time between radiotherapy and surgery?
Whenever your skin heals, usually 6 weeks.
Okay. And we'll
assess the skin.
Assess the skin. Yep, thank you. We'll take this as the last question. And probably these are above FRCS, to be honest with you guys. Do you use Merrill score in children, and does remaining life expectancy affect your surgical decision for kids and for different tumors?
So metastatic bone disease, remember, is number one, not very common in kids, for starters. Yes, you can use Merrill score in children. I am not aware of why you cannot have never had to do it. What's your next question? Does remaining life expectancy affect your surgical decisions for kids and for different tumors?
See, I think that's a very strange question, because most of the time
I don't understand. Are you talking about primary bone cancers, or are you talking about metastatic bone disease?
To be honest, I suspect the person just means primary tumors, because kids tend not to have metastatic disease.
Exactly. So expectancy, I didn't quite get your question. You might want to rephrase if you want to ask that again. But I didn't quite get your question. Yes, life expectancy affects all decisions, but for primary bone tumors, I think it's more about whether they're chemosensitive, radiosensitive, whether you can get a margin. Those are the key things on your surgical decisions.
I'm just
Can I mention a case that we've had just recently, and that hopefully would probably mean what the questioner has been asking.
Okay.
We've had a child who is autistic, who is about 13 of age, severe autism, who was found to have a widely spread osteosarcoma in different parts of his body, including the spine. So he had a pathological fracture of the humerus and a pathological fracture of, I can't remember where, the wrist, I think.
Okay.
No, actually the talus. And because of the widespread, he had neurological symptoms in his spine. So we asked the oncology team and the renal and all the other teams that are involved in his care, and they felt that the prognosis was poor and that he would live for 6 months. So in this case, what would you do for the humeral fracture? How would you fix it? How would you do anything for it, or would you leave it to be treated conservatively? So I think that would probably, put an example on the question that the asking.
If I were to answer the specific example you gave, it's an osteosarcoma, and the patient needs systemic therapy. It's widespread metastatic osteosarcoma, so the patient needs systemic therapy. So if the humeral fracture needs surgery, you're not going to achieve anything by resecting it, so you can stabilize it. If it needs stabilization, I would have probably used a humeral brace and got the patient on with their chemotherapy, right? So again, if in the exam, if you're asked this scenario for you, just don't get into a hole. Just say, this is a challenging clinical situation. I will discuss this in an MDD approach with my medical oncologist. I believe the principles are this child needs systemic treatment first, and therefore the orthopedic treatment can be as minimally invasive if at all, as possible. So I'm not going to give any survival benefit. The buzzwords here will be by resecting any tumor out, got 2 pathological fractures with widespread metastasis. I'm not going to give any survival benefit to the child. These will all be palliative procedures, so we can potentially fix the fractures as, as staying as minimally invasive as we can. Just so wrist fracture can maybe K-wires, and humerus can be whatever you want, maybe a humeral brace, and then carry on with the systemic treatment. As the child lives and, we see the response to treatment after chemotherapy, then we could always revisit this.
So to remind everybody, guys, you're doing the FRCS trauma orthopedic exam. One of the key points about this exam is your safety as a surgeon.
Yeah.
And you're not expected to be you're not expected to be a professor of sarcoma surgery when you're taking this exam. You're not, and some of you may be, but that's not what the expectation is at this level of the exam. This exam is about your year 1 DGH level consultant surgeon who's just starting his practice. These are cases that you should not be taking on without discussing with someone senior and your sarcoma service and using an MDT approach. Invariably, that is the right answer. And then you can go into the other details, because once you've said that, you're safe. Once you've said you will do this, this is your reflex action. Everything else you say after that, well, he's going to talk to someone senior before he instigates that plan, which is crazy or something like that. Does that make sense? I hope that makes sense.
Yeah, completely agreed.
Okay. Okay, we'll stop the recording here. Thank you very much, Atar. This was an amazing talk, as always, and it's really important to rephrase our thought processes on how to deal with metastatic tumors, but for the exam, as well as in the way we approach it in our patients. Really valuable talk, really appreciative, and really well explained. Thank you so much. We'll stop the recorded version here. Just a reminder, and we'll then move on to the Viva session, which is the unrecorded section. Thank you very much, everybody. Oh, before we stop, sorry, my apologies. A reminder that if you want to know our future webinar sessions, please do look up the FRCS mentor.co.uk website and stick with us on the Telegram group as well. You can register in advance for these sessions as they come up. Thank you very much, everybody.